This is an overview of an article entitled The Ability of Patients to Distinguish Among Cardiac Genomic Variant Subclassifications, published in the June 2018 issue of Circulation, Genomic and Precision Medicine. Clinical genetic testing using large multi-gene panels and whole genome or exome sequencing is becoming commonplace in the assessment of familial cardiovascular disease. In some families, these methods can identify the rare genetic variants that are responsible for causing disease. However, not all testing is conclusive, and receiving an uncertain result from a laboratory can be challenging for both providers and their patients. Updated guidelines from the American College of Medical Genetics and Genomics and the Association for Molecular Pathology recommend that genetic variants be divided into 5 categories: pathogenic, likely pathogenic, benign, likely benign, and variants of uncertain significance, or VUS. However, some laboratories use classification schemes with different descriptors, or more than 5 categories. How patients react to the 5 established variant classifications, as well as other classification schemes, is unknown. In the paper under discussion, the authors tested whether participants perceived differences among these genetic variant classifications. The authors presented participants enrolled in a large sequencing study with 3 hypothetical scenarios of cardiovascular genetic test results. One scenario asked them to imagine receiving a likely pathogenic result, while another asked them to imagine receiving a variant of uncertain significance result, 2 of the standard classifications. In the third scenario, participants were asked to imagine receiving a possibly pathogenic result, a classification that represents a subclassification of the VUS category. Participants were presented with the scenarios in a randomized order and completed a survey about their perception of the level of risk and uncertainty associated with each scenario and how they might respond. The study participants were recruited from 2 cohorts from the NIH ClinSeq study. The first cohort included primarily individuals of European descent, whereas the second cohort included individuals of African American, African, or Afro-Caribbean descent. Individuals from both cohorts were generally of high socioeconomic status and characterized as early adopters of new health technologies. Approximately 1/4 had a diagnosis of atherosclerotic heart disease. Of the 490 individuals contacted, 289, or 59%, completed the survey and were included in the study. First, the authors assessed the extent to which participants discerned differences among the 3 scenarios. When presented with all 3 types of genetic feedback, participants appreciated that the risk was lowest for the VUS result, higher for the possibly pathogenic result, and highest for the likely pathogenic result. They also expressed different intentions in response according to the same pattern. For example, participants indicated they would be more likely to share their result with a family member if they had received a high-risk, likely pathogenic result. Next, the authors compared the participants' responses to only the first scenario with which they were presented. While participants associated the likely pathogenic classification with a greater risk, compared with the VUS and possibly pathogenic classifications, they were less likely to make distinctions between the possibly pathogenic and likely pathogenic results when expressing intentions regarding future actions. This suggested that when participants were presented with a single result, a common circumstance in clinical practice, they were less likely to appreciate differences between variant classifications. Lastly, the authors performed mediation analyses to understand if a participant's perception of risk and uncertainty could explain the relationship between each of the variant classifications and the participant's intentions. To do this, they conducted a separate analysis for each pairwise combination of classifications. One example comparing results for a VUS and a potentially pathogenic variant is shown here. When presented with all three results, participants tended to be more deliberative and rely less on emotional responses, compared with receiving a single result. For example, when participants had a greater negative emotional reaction to the first result they were given, they showed greater intention to share results with family members. This suggested that their decision-making regarding the first scenario was more informed by emotion compared with when they were exposed to all three scenarios. In summary, the authors found that a participant's ability to distinguish between variant classifications depended on whether the result was presented in isolation or with other results. This suggests that patient perceptions can be influenced by the context in which genetic test results are presented, and that further subcategorization of the genetic variant classification system is unlikely to improve perceptions of risk and uncertainty among those receiving a single genetic test result. This study may help inform future guidelines for the interpretation of genetic variants in familial cardiovascular disease.